Our first speaker is Dr. Samir Sinha, and he's going to be speaking today about acing age-old issues in the care of the older Canadian. And our Dr. Sinha is the Director of Geriatrics at Mount Sinai and the University Health Network Hospitals in Toronto. He has consulted and advised hospitals and health authorities in Britain, Canada, and the United States, and as well as China, on the implementation and administration of unique, integrated, and innovative models of geriatric care that reduce disease burden, improve access and capacity, and ultimately promote health. So please give him a round welcome, and thank you so much.
So thank you very much, Michael, and thank you for everybody for coming out today. It's great to see that, especially that this year's Innovation Day is focused around aging, and so you have an all-star lineup, and I'm happy to lead the pack and share with you and help frame the day as we start talking about a number of different aspects of geriatric care. So I have no disclosures to give you, but I have objectives. And these objectives include just talking a little bit some of the problems that we actually have in the way we currently are geared towards delivering care, and why I always argue that they require an elder-friendly approach. I'm going to just talk a bit about the elements inherent into an acute care for elders approach to care, and then talk a little bit about the strategy we've implemented at Sinai, but have also been working with hospitals across Canada and around the world now to really help transform the way they provide care so that we can better meet the needs of our aging population. So I like the invocation we had just before, talking about, thinking about what we learn from our patients over time, and how we start thinking about aging, and how we think about the importance of courage, we think about the importance of love. And then I also think about how we actually think about aging in general. And these are two terms. Well, I think the second term is the term we often hear quite a bit, and that's the idea of tsunami. How many people have you heard referring to aging as a tsunami? Yeah, pretty much everyone. How many of you hear it talked about as a triumph? Maybe a handful, right? So it's this idea, is aging a tsunami or is aging a triumph? Well, I'm going to ask that all of you after today never use the term tsunami anymore, because anybody who uses the term tsunami doesn't know what they're talking about. Why? Because if you know what a tsunami is, these things happen without warning, right? Leave death and destruction in their past, right? They just pop out of nowhere. But have any of you heard of something called a baby boom? Okay, because if you were aware of that and kind of knew that, God forbid, these people might actually age over time, right? We kind of knew that we were aging, right? We knew that we would actually get here. But now, we have a lot of policymakers who are like, what? And even Michael just talked about some of the statistics that are going to be happening. You know what the future is going to look like in Georgian Bay. So why is this a surprise to any of us? That's not a tsunami. That's just bad planning and forecasting, right? So that's the opportunity. But why do I talk about triumph, right? Why do I emphasize that word? Because what was our life expectancy back in 1900 here in Ontario? Oh, you got a lot of pessimists here. Okay, yes. So we have 45. I heard someone say 25. It was actually, so in the Roman Empire, it was 35 years of age, okay? But actually, back in 1900, it was 51 years of age. Okay, that was the average life expectancy. Today, it's about 82, right? So when people say, what was the greatest achievement of the 20th century? Some people say we put a person on the moon. I think the fact that we almost doubled our life expectancy is pretty damn good, So how do we think about that? And this is why I try and emphasize the triumph of aging and that opportunity. But as you've heard, aging isn't easy, right? And we've got to be prepared for it as we move forward. So I just want to share with you some statistics here just to help frame, why we need to be thinking about our aging population in a little bit of a different way. So when you look at our stats in Canada right now, of our older population, we know that 17% of our current population are 65 and better. But we know that this number is going to double in the next 20 years, right? So the number of older people are going to double. The number of those who are 85 and better is actually going to quadruple. And who knows what the fastest growing age group in Canada is today? Over 100, absolutely. That's the fastest growing age group in our country. Now, when it comes to healthcare, because when you start thinking about, okay, the beds we have here at the Collingwood General Marine, when you start thinking about how many hospitalizations are accounted for by this small proportion of the population, we quickly see that older adults represent 42% of our overall hospitalizations across Canada. But we also tend to see that older people tend to stay longer in hospital than younger people, and that's why we know that about 59% of our hospital days in Canada are accounted for by older adults, right? So it's remarkable, because then all of a sudden you see that very few hospitals actually say geriatrics is our core priority. But I argue that geriatrics is the core business of any hospital that's caring for older adults. It's basically what we're doing today. And you can imagine, I grew up in Winnipeg, and I come to Ontario for my medical training, and then you're like, wait a minute, I think in Ontario, your senior strategy is that when you turn 65, maybe you move to Collingwood, but you don't get a place on the water, you get it in the hospital, right? Because I bet you, if you count all of your beds here, you've got people who are like, yeah, like they show up with their suitcases, and they're like, apparently this is where the action is, right? So all of a sudden, this is the paradigm that we actually have. But this is where it gets complicated, because people think that, wait a minute, all older people live in hospitals. But we've all heard those rumors about there are older people like my parents who are still practicing as physicians. They're also planning on playing with the grandkids this summer. They're also planning to do some travel, right? They're not planning to go live in a hospital, maybe work in one, but not live in one. So the question is, wait a minute, why do we have so many people living in hospital, but we hear about other people who are living beyond? And we actually know that 10% of our users of healthcare, of our older users of healthcare, actually account for 60% of all healthcare spending related to older adults. Let me put that in perspective. So our current healthcare budget in Ontario is $60 billion, okay? Half of that spending, around $30 billion, is accounted for by older adults. Now, there are 2 million older Ontarians today, and 10% of those older adults, 200,000, account for about $20 billion in spending. Okay, so a very small proportion costing quite a bit. And when I showed this data to our Minister of Health about 5 years ago, she reasoned with me that it would probably be cheaper if we actually just gave each of those 200,000 older Canadians their own geriatrician, a nurse, and a family, right? Because it would probably be cheaper to care for them that way than in our healthcare system, where it's very costly to care for these individuals. And why is that? Because when you look at this 10%, these 200,000 older Ontarians, we know they tend to be characterized by three factors, right? These are the people who spend most of their time in hospital. Number one, having what we call multimorbidity, multiple chronic health issues. Number two, having challenges with their functional abilities, their ADLs, their IDLs. And number three, they might be what we call socially frail, right? Having challenges, coping in the community with basic tasks like getting a prescription filled. In fact, we know that 27% of older Ontarians tell us they don't have a family member or friend close at hand who could help them do that task. So this is a challenge. This is what characterizes this population, and it helps us to understand why it's so expensive to care for them in a system that wasn't designed for them in the first place. And therefore, we get this issue. Right now, we hear about this theory or this idea of Canadians being stuck in hospital every single day. It's what we call our ALC crisis or our ALC issue. And we have about 7,500 Canadians who are stuck in hospital each day. They want to be able to go back home. They want to be able to go to a long-term care rehab a hospital, but they can't get there. Why? Because we don't actually have the right capacity in our system in order to help people to get where they need to go. And so that means about 16% of our current hospital beds in Ontario are accounted for by people who are stuck. They just can't get where they need to go. And that ends up costing us all as taxpayers even more money, because it's about $2.4 billion a year is what we spend just around the cost of people just waiting who are stuck in a system and they can't get around. And part of this then starts helping us understand, well, how did we get here in the first place? Because I took a bunch of healthcare leaders, deputy ministers and ministers over to Denmark a few weeks ago so that we could actually do an exchange, because Denmark actually remarkably runs a very similar system to the way Ontario runs, but they don't have hallway medicine, right? But then they were saying, we were meeting with their Minister of Health and said, well, tell me about your universal healthcare system, because your universal healthcare system you created 50 years ago when the average Canadian was 27 years only includes hospital care and physician services. In Denmark, when they built their system 50 years ago, they included things like medications, home care, long-term care. In fact, all of those are essential parts of the system, and that's why their average length of stay in the country is 3 days. 3 days, right? No hallway medicine. They just find it so bizarre to understand what we have, but they say, well, maybe take a look at what you call universal health care, because it doesn't sound terribly universal to us. So then the challenge is we've got people like my patient, Mr. W, who this was a portrait taken on his 100th birthday. This was during my follow-up home visit with him. And here's a guy who basically, was doing quite well on his own till 98. Lots of courage, lots of love, doing his thing. And then all of a sudden his CHF, his COPD, his arthritis, all of that kind of came home to roost. And all of a sudden he couldn't easily get out of his house anymore to go and see a doctor. And so for him, he became homebound. It was hard for him to even get down to the ground floor of the building he lived in to get his groceries and to get his medications. It worked really well for him up until 99, until he couldn't get out of his own apartment. And that was a challenge for him. And so all of a sudden, the only way he could start accessing care in our system was by calling an ambulance and going to one of the downtown hospitals. In fact, by the time I met him in the fall of 2010, he had actually been to our downtown hospital 7 times. Goes in, says hi to all the nurses and the docs, gets patched up, gets sent back, and then we'll see you in a month? Yeah, sounds good, right? Because I'm not going to get the care I need at home to be able to stay independent and healthy where I want to be. So this is a slide that I think really helps to illustrate kind of the fact that when we actually look at aging and hospital use amongst those who are 70 and above, this is a study that was done over 20 years ago, but the data actually holds true in Ontario today. I already revealed to you some of that data, but this is a study that looked at 7,000 older adults over a 7-year period and simply asked the question, how often do they go hang out in hospital? Because remember, I had that theory that when you turn 65, apparently you go live in hospitals. So I actually looked up this paper and it said, actually, no, Samir, that's not the case at all. In fact, over a 7-year period, the 7,000 older adults who were followed in the American Longitudinal Study on Aging basically showed that half of them never went anywhere close to hospital. Again, they were, playing, in the community, doing their thing. They were staying very far away from our hospitals. About 24% were those individuals who used the hospital once over that 7-year period. And that might have been to get an elective knee or hip replacement so they could continue living healthy and active lives. The rest of the pie that would add up to 100%, so about 33% of these older adults used the hospital 2 or more times. And in particular, this gentleman, Walensky, who did the research, he established that about 6.8% were what he classified as inconsistently high users, and then about 4.8% were those who used the hospital on a consistent basis. The consistent people, like my patient, Mr. W, who you just met, who had CHF, COPD, that brought him into hospital like clockwork. The inconsistently high users take him and then give him a mental health diagnosis or dementia, because that makes your use of healthcare highly unpredictable. In fact, having a diagnosis of dementia increases your risk of hospitalization by 3-fold, right? We don't remember when they're going to stop taking their medications or their insulin, and then lands them in. But the key part of his work and the key part of what I just showed you before with our Ontario data is only a small proportion of older adults are extensive users of hospital services. And remember what I said before, what defines that 10%, that greater group, that again, 200,000 people in Ontario that cost $20 billion to care, it's these 3 factors: polymorbidity, having functional impairments, and again, that concept of social frailty. Right? So now as a geriatrician, when I look at the patients who come into my hospital, I often look for these 3 factors, because if I'm not addressing all these issues, if I just simply patch up your CHF, your congestive heart failure, and send you back home, and I forget the fact that you don't actually have someone to help you get your medications or administer your medications, or the fact of the matter is you're going to need a little bit of extra help at home until you get back on your feet, there's no reason why they're not going to end up back in the hospital within a few days. So it's having a better lens and seeing the people in front of us who we're caring for, and then figuring out how do we adapt our healthcare system that again was developed 50 years ago when the average Canadian was 27 and could do just fine at the Collingwood General Marine Hospital or Mount Sinai, but that 87-year-old not do so well. So you think about people like Mr. W. Mr. W is fine. He doesn't have any cognitive issues, if you will. And, at his own home, he could actually get around with a walker, and he'd have a personal support worker come in every day, get him bathed, get him dressed, and he was good to go. Like that's all he needed to do, and he was good. But of course, you then give him an illness. We'll give him a pneumonia, for example. That's what brought him in when I met him back in September 2010. And the key is that we know that many older adults, frail older adults, they have less functional reserve, right? They're not as big and robust as they once were. And so his challenge that he'd always have is whenever he'd actually get sick, whenever any of us get sick, we feel a bit weaker. And that weakness meant that for him, getting up and out of a chair, often on and off a toilet seat, became a struggle, right? He had trouble with his transfers, one of those basic ADLs. That would lead to a fall. He had a son who didn't live in Toronto. He told his son he had a fall. His son thought, yeah, I'm going out of town for business. I'm not going to be in Canada. My dad, he's 100, and he's just had a fall at home, and he's got a little bit of pneumonia. Maybe I should just send him to the hospital. So before he flew out that night, he called 911 and sent his dad to the hospital because, of course, I'm sure at your hospital here, just like our hospital, that's exactly when you have extra staff taking on extra shifts, and you're staffing up just to make sure you're absolutely ready for all those older people, who coming in on the weekend. And that's a challenge, right? Mr. W came into our hospital, a hospital just like your hospital here, where you have dedicated staff who are there to provide the best possible care. But sometimes we don't realize that the care we're providing, again, geared towards 27-year-olds, not 72-year-olds, or 100-year-olds for that matter. So these tend to be very hostile environments, right? So at our hospital, we write in the orders, Kevin will know, he trained there as well. It basically says in order to get, 600 patients their blood work on time for our surgeons and doctors in the morning, we actually are allowed to wake you up as early as 4 a.m. to poke you for blood work. Now, how many of you were up at 4 a.m.? Number two, how many of you want to be woken up at 4 a.m. to be, phlebotomized, right? Now, imagine if you're an older patient with dementia, right? And someone wakes you up and then pokes you. What do you think just happened to you? You probably thought you just got assaulted, right? Now I might have more behavioral issues. You can start seeing how this is a problem. Now, who cares that Mr. W would have his breakfast at 11 a.m. in the morning? Because I'm sorry, you're now calling with General Marine. You get your breakfast at 8, you get your lunch at 12, you get your dinner at 5. And if you don't eat it at that time, it might go cold. We often strip you out of your clothes. I don't see any of you wearing the fashion that I was seeing up on the wards there. None of you are wearing hospital gowns. I don't know. Like everybody here is wearing them. Why aren't you, right? Because again, we strip you out of your clothes. I don't have the time because I'm so busy caring for so many people to learn your name. So I'm just going to call you honey, sweetheart, or dear. Yeah, might pat you on the head and say, there, dear. You can see how these can be incredibly demoralizing and not great experiences. And then, of course, Mr. W didn't feel well, right? He didn't feel great and hot when he came to the emerge. So the nurses just thought, you know what? Just stay in bed. We'll put a catheter in you to help you urinate, right? We'll give you an IV, and again, nobody was trying to cause harm here. But that bed rest we know for older adults, every day an older adult is in bed, they lose 5% of their bone and muscle mass. You lose percentage points of your bone and muscle mass every day. You lose 5% of your function every single day you're in bed. It's why Mr. W, when he came into hospital, he could independently get around his apartment with a rollator walker. 48 hours later, by Monday morning, this gentleman was what we call a two-person assist. He needed 2 people to assist him to get to the washroom. And it was amazing to see this guy who was living independently in his own apartment, cognitive intact, and watching the student notes over the weekend saying, 100-year-old guy, most likely demented, disposition plan, nursing home. Wow, we just completely wrote off this 100-year-old within a 48-hour period, and that's not what he wanted. He didn't even want to come to the hospital in the first place. And then we wonder why we have all these people waiting for ALC and why we have all these people waiting in our system, because maybe we're not actually figuring it out well. And then we have all these other challenges that happen, things that can lead to medical complications and other things. And all of this leads to more physical deconditioning. So for Mr. W, by being a two-person assist, even though his pneumonia had been treated, his delirium had cleared, he got delirious, by the way, too, in our busy emergency department, that by Monday morning, even though he was actually better in some respects, because he was so functionally disabled now, it took us 2 weeks to rehab him before we could get him back home. Yeah, I decided we weren't going to send him to a nursing home. He didn't want to go. He wanted to go home. But now I always said, We broke him, we bought him, right? That's 2 more weeks now that we have to rehab him to get him back, because he's like, I'm not going anywhere else. I'm not going to a nursing home. So you broke me, you fix me, right? So we just spent 2 more weeks, and then we wonder why 16% of our beds are filled with these people who don't want to be there, right? In fact, I always say we're almost holding these people hostage in a system that wasn't meant for them. So this is our recipe, and then of course we get headlines like this saying that, you know, our hospitals are unprepared, you know, for an aging population, and we know that if we actually do nothing differently, again, remember, we built a system 50 years ago for 27-year-olds, and so this is actually how we spend our healthcare dollars in Ontario, 60 billion, don't forget. This is actually how we spend it based on age. Obviously, the older you get, there's more mileage that you experience. That's where more of the billions get spent, but this is actually what we forecast what our spending will be like in 2030. This is how much more money we will need. We'll need $24 billion more from what we were spending in 2010 just to finance caring for an aging population with the exact same health system I just described today. So of course, you're probably looking at that recipe that I just showed you and said, well, wait a minute, maybe if we did things a little bit differently, we wouldn't actually be maiming people like Mr. W. We could probably get him in and out pretty quickly, and we might not need to find $24 billion more. Maybe, in fact, we have enough money in the system that if we do things differently, we could actually have a different outcome. And that's the challenge, is I would say that the way, not only in which our hospitals, but the way our cities, our communities, and our healthcare systems are currently designed, resourced, and organized often disadvantages older adults with chronic health issues, but at the same time, as Canadians and Ontarians, our care needs and preferences and values are evolving as a society with increasing numbers of us wanting to age in place. This is why I wrote an op-ed in the Star the other week, where I basically gave permission because, I'll ask you, this is what I asked in the newspaper. I challenged all the politicians from all parties. I said, how many of you in this room, I'll ask my question to all of you, how many of you aspire to end up in a nursing home? Are you raising your hand, Michael? No. He was just scratching his face. Okay, there you go. So, but here, we had all 3 political parties saying that they're going to build 30,000 new beds because apparently that's where Mr. W didn't want to go, and that's where apparently all of you don't want to go, which is a problem because most of you probably want more home care and community care to be available as well. So this is a challenge, right? So how do we actually look at developing an elder-friendly approach, and how do we move things forward? So when we had Mr. W in our care, that was the time when our hospital said, you know what, actually our core business is geriatrics, so let's admit it, let's embrace it, and let's start working on it. So that was my mandate at that time, and Mr. W was one of our great test cases because he came in and we just saw how many things actually went wrong. Not that anybody was to try to cause harm, but how we actually had a system that was working against him. And so we sat down as a group of nurses, doctors, social workers, our geriatric psychiatry team, everybody. We got together, and our community partners, CCAC at the time, etc., and we said, how do we actually redesign a better mousetrap here? And so we came up with this strategy. We basically said we want to redesign or establish innovative and sustainable approaches, interprofessional, team-based approaches that could help enhance upon service current models. We knew that this would require a shift in traditional thinking that underpins the administration organization of most hospitals, because we know most organizations often, they don't recognize the fact that they actually are caring for older adults. In fact, when we actually established this as our priority, we were one of the only hospitals in Canada actually saying that geriatrics is a core priority. Most hospitals still don't acknowledge that in Ontario. Next, we actually said that we're not going to be adverse to identifying risk factors and needs and intervening early. You know, what we want to do is we want to make sure that we're identifying the Mr. W's, that 10%, because if we can change the trajectory for them, we can actually improve the healthcare system for most folks as well. And we want to make sure that we have a focus on monitoring our data. How are we actually doing and how are we moving that forward? And so we use this idea of the elder-friendly hospital model, one where we actually look at the culture. We have an organization that says geriatrics is a priority. You cannot work at our hospital unless you've actually done aging sensitivity training. Whether you work in finance, whether you work in the coffee shop, if you're a volunteer, you all have to do the training. And we make sure that everybody values that we're an organization that cares about older adults, and we're an organization that understands and respects their needs. We make sure that we think about the policies and procedures we have in place. We make sure that as we redesign redesigning. We're doubling the size of our emergency department right now, all built towards elder-friendly standards. Our new lobby, all built to elder-friendly standards. Any redesign we do, all done. It doesn't cost any more money. It just means that we have to be a bit more smart when we think about how we do our layouts and our things as well. And how do we actually manage the care in different ways? And all these ideas work together to better improve the care of older adults. So this is actually what our work has ended up looking like over the past few days, or the past few years, if you will. And we've really focused on the importance of building community models of care. So we've really focused and partnered with our community partners, our primary care partners, and others to basically say, what are some of the things that we can do, such as creating a home-based primary care program so Mr. W could work with a team of family doctors that could actually deliver care for him in the home. We offer home-based palliative care supports as well. And we have other programs that will be familiar to you, community paramedicine, nurse-led outreach, all these sorts of things that we do to try and do better supports in the community. We also have a caregiver program that's now being spread across the province through the Alzheimer's societies, where we train caregivers caring for loved ones with dementia to better support them as well. We also focus in our emergency department about screening every older adult who comes in our doors to make sure we identify the high-risk ones versus the low-risk ones. The higher-risk ones get to work with our geriatric emergency management nurses, and they're working amongst a whole team of staff that have all been trained towards caring for older adults. In our inpatient wards, we've actually reorganized our services so that we actually cluster our frail older people onto a specific ward called our ACE unit. And that ACE unit is where everybody's gotten extra training and skills so that they can better care for older adults. And then we have a number of other programs. All of our all of our hip fracture patients get cared for by geriatricians 7 days a week. We start right when they come in because we know that they're at high risk for negative outcomes. And we also engage our volunteers to be highly engaged and trained to work with frail older adults. And then we have our outpatient services that we run as well, including telemedicine, to help get people the support they need. So I'm going to finish off quickly because I'm running out of time, and basically just give you some examples. This is our new emergency department, and I love it because our current emergency department has 2 bathrooms. Our new emergency department's doubled in the size, and we have more than 4 bathrooms there. The key is, this is what the chief nurse said, if we have many more bathrooms, there's no reason we need to catheterize patients. We can actually make it easy for our nurses to get people to the bathrooms as well, and this really emphasizes that. This is an example. You all get copies of these slides. This is an example of the simple screening tool that our nurses ask as part of the routine care to identify who's at high risk, who's at low risk, and enables them to create a care plan in place as well. This is our free online training program called GeriEM.com. You cannot work in our emergency department at any level unless you do this training. It's free. It's available to anybody around the world. In fact, 5,000 doctors and nurses have taken it already, and it allows people to up their game to do that care. I've talked to you about our GEM nurses, who are specialized geriatric emergency management nurses. And this is one thing that we've done. Working with our community partners, we've actually created a system at our hospital that if you're one of our high-risk patients and you end up in our emergency department, we have an email alert system that allows all of us across the hospital and the community to talk to each other. That way, when this was one of Mr. W's alerts 3 years later, when he had his hospitalization after I saw him, after that, we all knew that he was there. We knew what we needed to do. We didn't need to admit him to hospital because we could rally services together. And we've changed our order sets. So now if we actually say activity is tolerated, which is default, it means that you need to be up in a chair 3 times a day for meals. Because we're not the hotel. We're not serving breakfast in bed anymore. We're getting you upright in a chair because that's going to help you with your functional recovery. And we're using data that we mine from our electronic health record to help inform nurses to do real care time planning to better support their care. And the nice story is that we're actually seeing results. Now, our hospital's in a busy part of Toronto. It's growing quite quickly. And while we have the lowest emergency department admit ratio, meaning if you come to a GTA hospital emergency department in Toronto, you have a 35% chance of getting admitted as an older adult. You come to my hospital, it's 25%. So it's tough to get admitted. But we have 53% more older patients on our wards. At the same time, we've actually cut our lengths of stay for older patients, 65 plus, by 26%. We've decreased our readmissions by 14%. So we're getting getting them out quicker, but we're making sure they're better supported when they go home. We've actually cut our pressure ulcers by 93%. We've cut our falls by 66%. We've cut catheter utilization by 50%. All nurse-led initiatives. Our patient satisfaction's at 99%, and last year we've saved $6.7 million because we're not paying for people to wait around here anymore. They got better things to do, and we've actually closed 25 of our medical beds since I started at the hospital now. We have less beds than ever before because we don't need them, right? And so we're working with organizations across the country. Don't think this is something that you can only do in a shiny hospital in downtown Toronto. We worked with hospitals, for example, in Geraldton, Ontario, which is about 400 kilometers north of here, and they were able to implement some of our models as well. And we've been working with organizations across the country with CFHI and CFN to help them implement some of these models of care. So there are many opportunities to think about how to move forward in terms of the integration of LINs and CCACs, and some more recent community investments can be seen as an enabler. Number two, thinking about how do we engage our staff, volunteers, and community to build local models of care that make sense and deliver better outcomes. Leverage any enabler, housing, transportation dollars to build a continuum of care. There's a lot of good things happening in this community, and the key is how do we actually collaborate and say, how do we think about the hospital as part of a broader health system, and how do we think about our municipalities as real key partners, because it's amazing when you get everybody aligned what can be done. There's new dollars coming through the provincial dementia strategy initiatives, and these are investments that can help create more integrated care models. And finally, we want to make sure that we leverage technology and help leverage technology to improve that rural effect. And the bottom line is that Georgian Bay, providers have a lot of enablers that can allow us to advance this agenda. So I hope this is helpful, and I wish you luck for the rest of the day as well. Thank you.